What?
A very good evening, everyone. Myself, Dr. Gaurav Luthra. You are welcome to this IIRSI webinar on modern LASIK surgery, ray tracing, Contoura, and lots of other stuff. We have today with us a galaxy of speakers from India and abroad, and we have some authorities in LASIK, and we are going to talk about all the new technologies which we are going to be look into, which we are performing today, which we are likely to perform tomorrow, and the future of refractive surgery. So with me is Dr. Vavikar, who has helped me put together this nice webinar, which we both of us are going to be moderating this. And I would love to introduce my uh, panel and my faculty. I'll just share this screen. Uh, for some reason, it doesn't show my PPT. It'll take a moment, please. I'm sorry. Okay. So, all right. This is always a bit of a challenge sometimes. Okay. So we will have 2 hours of 1.5 to 2 hours of discussing all this. And we have a galaxy of panelists with us. Professor Mahipal Sajdev, who might be able to join late. He's also stuck with another webinar. He's president of the IIOS and also chairman scientific committee of the Intraocular Implant and Refractive Society of India. We are missing today Dr. Amar Agarwal, who has been, the motivation to do this webinar and could not join in today because of another commitment. We have another senior panelist, Dr. Arulmozhi Varman from Chennai, from the Uma Eye Clinic, who's a renowned cataract and refractive surgeon and is prolific with his work, and he will be chipping in with a lot of wisdom here. We have Dr. Neeta Shah, who's director of the Ayush Eye Clinic, Microsurgery and Laser Center, and that she's out of Bombay. She's again a very dynamic refractive surgeon and is doing fantastic in refractive surgery. We have Dr. Nitin Balakrishnan, again a dear friend, Chief Medical Director of the Saideep Eye Clinic and Crystal Vision Laser Center in Mumbai. Again, a very committed refractive surgeon, does a lot of Contoura surgery, and he's been very active with us in this front. We have with us the president of the IIRSI, Dr. G.S. Dhami, who is director of the Dhami Eye Care Hospital from Ludhiana, and he will be again joining us a little late. He's on another webinar. He'll be shortly with us. We also have with us our speakers who are the who's who of refractive surgery. We have Dr. Arthur Cummings, all the way from Dublin. He's no stranger. We have been using his pioneering work right from the time we started using our wavelight platforms almost 15, 20 years back. He's a prolific refractive surgeon. We have Dr. D. Ramamurthy who's the chairman of the Eye Foundation, past president of the AIOS, and also chairman scientific committee of AIOS. Dr. Vavikar will be introducing our speakers later on. We have Dr. Mark Lobinoff, again, head and founder of the FourSees, director of the refractive surgery at Minneapolis in Minnesota. He's again one of the driving forces behind the FourSees software, which we all use for our Contoura surgeries. We have a young and dynamic Dr. Nikhil Balakrishnan, who has just finished his fellowship at Narayan Nethralaya in Bangalore. He will be sharing his wisdom on Contoura. We have with us Dr. Rohit Shetty, who is vice chairman of the Narayan Nethralaya in Bangalore. Again, he's no stranger to all refractive surgery panels. In fact, he's one of the brilliant scientists that India has produced, and we will talk more about him later. And we will be joined by Dr. Sanjay Chaudhary, who's chairman of the I7 Eye Hospitals in New Delhi, is doing fantastic work on Contoura Vision and lots of other surgeries. And with me is Dr. Vavikar, as I just explained. I'll stop sharing the screen and I'll invite our first speaker for the day. Professor Arthur Cummings from Dublin in Ireland. He's a dear friend. He's agreed to be with us today against all odds. He's committed in several webinars for the day, but we couldn't miss him for this webinar and I had to really rope him in. He's been the past president of the ACOS, the American European Association of Eye Surgeons, and also he's a vice chairman of the Refractive Surgery Alliance. Now, Arthur has done amazing work. I remember when I started using Wavelight first, and they came up this Wellington nomogram, and this was I later on got to know Arthur over the Wavelight meetings that we did over the years, and he's been the guy who's been behind so many research works. Of late, the latest research he's done is on the ray tracing on the Wavelight platform. And I always look forward to his wisdom, and he's an amazing speaker. So with that, I won't keep you away from Arthur, and he's going to speak to us about how ray tracing is coming up, and how it might even replace some of the current technologies that we use. And Arthur, please go ahead.
Thank you so much, Gaurav. That's such a wonderful welcome. I hope I don't disappoint. I'm looking forward to my own talk after hearing the introduction. So I'm going to speak to you about ray tracing ray tracing in the time of Contoura, or the other way around, Contoura in the age of ray tracing. First of all, I'm delighted to be amongst this galaxy of stars. I think it's going to be a very, very nice session. So these are my financial disclosures, and these that have application today are Alcon and Wavelight. So I'm going to first...
Arthur, can you just hold on? I'll request the admin to please mute Dr. Dhami, whose mic seems to be on and he's not aware of it. Please go ahead, Arthur. Sorry about that.
So topography guided procedures for a first-time laser vision correction, that's what the definition of Contoura is. Sometimes it's slightly confusing because most of us who've been using this for many years sort of used topography guided for repair work. But in Barcelona at the IIRSI in 2015, so close on 5 years ago, for the first time, we saw the results of the FDA study, which was topography guided Lasik on myopes and using placido disc on first-time procedures. And that became known as Contoura Vision. So Contoura is really for first-time procedures. And the results were fascinating. 98% of subjects indicated that they would have LASIK again, and the symptoms generally improved over time, especially through 12 months. And then there was statistically significance was achieved for all light sensitivity, difficulty driving at night, reading difficulty, and glare with TCAT LASIK. So all the potential issues that people could complain about were addressed with Contoura. So what happened in the real world? In the real world with Contoura, there were three perspectives. The one was using the manifest refraction, which is what the FDA study did. The other one was using something called TMR, topography modified refraction, which was started by John Kanellopoulos. And the third one was a hybrid, which many of us were using, which is something in between where you were assuming that the posterior cornea and the lens and the retina might also play a role in astigmatism. And just for basic background, just to give some, here's a cornea with astigmatism, but in this particular case, the manifest refraction is slightly off axis, and that's what you would do for a manifest treatment. If you were doing Contoura, you would go directly on the axis and magnitude of the corneal astigmatism. And if you're doing some sort of hybrid, it would normally be somewhere in between. So with manifest refraction Contoura Vision, on axis of the refraction, you had to make sure that there was excellent correlation between the manifest refraction, both still axis and magnitude, and this needed to correspond very well with the topographic. And then when you looked at the higher order aberration profile, it needed to be less than 7 to 10 micron. And if you did that, you'd get a very good result. So here's your topography. You're now going to look at a zero powered higher order ablation profile. And if you look at this in more detail, you'll see that the highest ablation here is 8 microns, so it fits the definition. And if you did this, you could expect to get the FDA results, which was spectacular. If you did TMR on the topographic modified refraction, John Kanellopoulos introduced this using the topographic cylinder and axis, and then doing a calculation to modify the sphere equivalent. And John showed that when he had 100 eyes in 50 patients, one eye TMR, one eye topography guided, he found better results with TMR. Now, I didn't find the same thing, and I know many papers, especially out of Canada and Asia, India, also found that they were getting better results with manifest than with TMR. So all again it said to us was that it's confusing. And then the hybrid Contoura Vision was something where we were doing in between. And this was where we thought to ourselves, there's got to be more astigmatism in the optical system than just the anterior cornea. The posterior cornea is adding something, the anterior and posterior lens surfaces maybe, as well as the retinal architecture. So the taught methods to date were taught on Wavelight courses. Noel Alpins has a vector analysis. The ray tracing technique takes care of it automatically. I'll speak about that in a moment. And then the FourSees, which I won't go into much detail at all because Mark Lovanoff is on the program. So my personal perspective with TCAT was, first of all, in terms of predictability. Our R-squared was about 0.96 with wavefront optimized. And that was simply because with wavefront optimized, you're entering your refraction in 0.25 diopter increments. With custom Q, it was almost bang on target, because now using software like IBRA or Surgery Vision Consultants, or there are quite a few of them that can refine your nomogram, you could key in, instead of 3.5, you could key in 3.61. And that really did make a difference. And then we were getting similar results with Contoura, but slightly overcorrecting. And that's just our interpretation of the higher order aberrations and not getting it quite right in terms of what the impact on the refraction is. This I found fascinating. In terms of stability, the procedure that had the best stability over time was Contoura compared to the others. And the reason was that the laser knows what the cornea looks like, and it does a treatment, and it weds this treatment into the untreated cornea in the best possible way. And we know that the epithelium remodels, especially where there's an acute change in curvature. But if the change in curvature is gentle, then the epithelium tends to be equally thick everywhere. So what is ray tracing LASIK? So for background, there's a new profile out that's currently undergoing a controlled launch. And there's two very important reasons why it's undergoing a controlled launch. The first one is the old ray tracing done 10 years ago was done on 3 different devices. And then the algorithm, all the data was sent to Zurich. It was put through the algorithm, the calculation was done, and 6 hours later, you got the treatment profile on a USB stick, plugged it in a laser, and did the treatment. So what's new about this one is this is one device. It's called the sitemap. So when there's a new device driving the treatment, you've got to validate it and make sure it's working well. And then the second thing is the treatments that were done with the original ray tracing study were over -4 and more than 2 diopters with astigmatism. And we needed to see now that this was going to work in an all-comer situation. So for background, irrespective of how we do a treatment, whether it's standard, wavefront optimized, wavefront guided, topo guided, custom Q, no matter how sophisticated the diagnostics are, is once you transfer that to the cornea, the laser thinks you're treating Goldstrand's model. And Goldstrand's model looks like this. It has a corneal curvature of 43 diopters, and it has an axial length of 24 millimeters. And Goldstrand won the Nobel Prize in 1911. And this is 50 years before laser was an issue, and many, many years before laser surgery. Yet we still use the Goldstrand model for every treatment we do, bar ray tracing. This is what made the difference. This is the lens star. It was licensed to Wavelight, and it has a wavelength at 820 nanometers, where the IOL master was at 780. And that allowed us to see the front and the posterior surfaces of the lens. And now you could really model, you could create a model. So now with this model, instead of using a refraction, you use a wavefront. And with the new device, the sitemap, it's a Hartmann Shack. With the previous device, it was a Cherning. Instead of using an arbitrary 43 diopters for the cornea, you're now using 24,000 points. You also have tomography telling you something about the posterior surface and something about the anterior lens surface. But what really made a difference was adding biometry, which now showed you along the visual axis exactly where these intersections were. And with that information, a wavefront, biometry, and topography, you can now virtually calculate the properties of the lens, and now you have the virtual eye. And based on the virtual eye, you can do these calculations. So something like wavefront guided, which is used, there are a number of things that are still assumptions where along the top ray, with ray tracing, we're measuring many, many more characteristics of the eye to create a better treatment. And then finally, it also included the expected biomechanical response based on the corneal thickness and the amount that you're treating, and also from the literature, the expected epithelial healing response. So the clinical outcomes way back then, from a multi-center trial, 127 eyes, 111 had 3-month data. It was only checked at 3 months. All of the data here in this first column is FDA data. The wavefront optimized is FDA data, and so is the wavefront guided. And when you look at FDA data, it's normally phenomenally good. But if you look at it in the range of -4 to -7, 80.8% were getting 20/20. Wavefront guided 91%. With ray tracing, 93.7. Over -7, 70.6 of wavefront optimized, but 90 of ray tracing. And no eyes were done over -6 with wavefront guided. And in terms of safety, this is my own data from my own clinic. I looked at patients with the same refractive range, and this is a very, very classic profile with more patients gaining lines than losing lines, and normally sort of 6-7% losing a line. Wavefront guided slightly better. Custom Q again slightly better. Topography guided, this is from way back when on complicated eyes. Contoura is obviously there's more eyes gained now, But with ray tracing, we found no eyes lost a line, and the majority of eyes gained a line. 75% of eyes gained 1 or 2 lines. So the rationale about this study was, we're going to take it now to a clinic environment with all comers that aren't necessarily more than -4 and more than -2 astigmatism. So it's all comers. How would it fare there? And so the controlled launch was early this year. And the only data I could look at was, what did my innervised eyes look like at the 1 month versus the ray tracing from 10 years ago at the 1 month. And innervised was slightly better. But COVID has really messed up our follow-ups. And the same goes for the other centers that are doing this. So at this point, I can't say anything more than we need more data to be able to say this is a better technology than whatever we have at the moment. It still needs some time. We've got to prove that the one device works, and we've got to prove that using a Hartmann shack rather than a churning is going to give us the results that we're looking for. This just shows you on the device what you have. You have the wavefront, you have the topography, you have biometry. On the wavefront, you can go look at them all individually, take out the ones you don't want. The same with the topography. You can also look at the posterior surface, and then you can look at the biometry. I'm going to shoot through to the end. I don't want to waste time at all. So I want to go on with, is there still a place for Contoura Vision? So Contoura on manifest could not compete with what the FDA found. So we simply couldn't find those results. And if you looked at the guidelines, only 10% of patients met the FDA criteria. So Contoura with manifest isn't really feasible. Contoura with TMR, likewise, again, could not compete with what the FDA found. So TMR is also not doing the trick. And I'm not going to say much about FourSees except to comment on Mark's great work in making this more of a science and less of a guess. And Mark's going to speak about these results there. They're really spectacular. And now, for the first time, people are finding results better than the FDA topo-guided trial. Sorry about this. I'm going to shoot through this. So my final slide is, Contoura is not going away, especially with the use of FourSees. It's an excellent tool for quality of vision. Innervised requires more hardware. So if you decide to go down the ray tracing route, you have to acquire more hardware. And 80% of eyes we can currently validate. You need to do a wavefront without dilation, and 20% we can't get that. And to date, Contoura surpassed the best FDA results to date. And it works very well. It's very tried and trusted. And it's fabulous to think we've got a product coming down the line, which is going to be one measurement to give you an ultimate customization. And once it's here, it'll be wonderful. But in the meantime, we've got wonderful tools to help us. Thank you very much for your attention.
Thanks, Arthur, for compressing your talk, of which should have taken an hour, into just so little, and yet being able to make such great sense. And I wish we could have like so much more time to hear you and your experiences on ray tracing. We will have a discussion right after the next talk, so I'll request everybody to hang on for that. And we are now going to invite our second speaker, Dr. Chandrasekhar Bhavekar, who is a dear friend from Mumbai. He is very passionate about his work, refractive surgery, cataract surgery. He has an amazing center in Mumbai, in Thane, which I happened to visit a couple of years back when it was brand new. It's all made of glass, a wonderful, tastefully done up center. And he has a passion for biometry as well. And I keep enjoying all the passion that Dr. Bhavekar brings with us, and he's been really helpful in bringing about this webinar today. So Dr. Bhavekar is going to speak on what is Contoura and how he's going to introduce Contoura a little way beyond what Arthur just did. So Dr. Bhavekar, please go ahead.
Thank you, Dr. Gaurav, for the nice words. And good evening, everybody. After a nice talk by Dr. Arthur, let us start about talking about Contoura in a little bit of detail. So Lasik was started in the second last decade of the last century, and it was clearly evident that all is not well. People had issues like glares and halos, and it was attributed to HOA, that is higher order aberrations. To handle these two approaches were taken. One is treatment of the pre-existing HOA, and second thing is avoiding addition of more HOA, inducing more aberrations while doing Lasik. In that, the first thing was improvement in the flap creation. Over the period of so many years, we are seeing better and better flaps from microkeratome to laser, and the bed quality has also been superior. Then the improvement in laser machines. From the big spots, we went to scanning and now flying spot technology. And but the most important improvement has been in the ablation pattern. We are talking aspheric treatment or wavefront optimized treatment here, in which more shots are given in the mid periphery to keep the prolate surface of the cornea as it is. On the other side, we are talking about the pre-existing HOA. Wavefront guided was the first to come in, but it was soon realized that not everybody has a high amount of HOA and therefore it has limited use. Then came FCAT or the Q adjusted, where depth of focus was adjusted by adjusting the Q value. And then lastly came the topo guided ablation. Now in topo guided ablation, if you see the map here, the ablation amount, ablation is different at different places. So because of that, the ablation depth is different. And therefore the standard Miller-Lin equation does not work. Therefore, there were refractive surprises. As a result of that, it became a two-step procedure. First, you treat the corneal irregularities, and second, you treat the refractive, whatever element is left behind. So it remained more as a reparative procedure for a long time. That means you are interested in increasing the optical zone or treating decentered ablation and so on. In between, there was one technique called as a topo neutralization technique, where by trying to adjust the color of the ablation, you try to take care of the refractive error, but it did not take up for a long time because it was somewhat arbitrary. There was less science in it. The major breakthrough came when C4 C12 compensation was thought. C4 in wavelet language stands for the defocus or the spherical error, and C12 stands for spherical higher order aberration. So there is a mathematical expression to convert the effect of ablation we are using to treat the higher order aberrations, okay, which will be seen in C12, and you do something to the C4 so that the spherical equivalent remains same. This is basically, we are talking about virgin. One more point which was evident is that our classification as LOA and HOA. LOA means the lower order aberrations or the refractive errors, and HOA is only for our benefit, but in reality, sphere and the spherical HOA and cylinder and the coma, they are in continuum and they are interchangeable at least to a certain extent. This is the screen on which you can see that there is a C4 and C12. C4 is here and C12 is here. Dr. Ramurthy will explain this in more detail. So what is done in Contoura? Vario topolizer is used to map the cornea. It checks as many as 22,000 elevation points. So we get a very, very in detail structure, corneal structure and the elevation maps. Then that is sent to the workstation where ablation profile unique to the patient is generated, and then it is treated by EX500 laser. It can be treated with 400 also, but EX500 has additional facilities which makes it better for Contoura treatment. The Contoura range is same as WFO Lasik. The optical zone can be adjusted in the steps of 0.5. Transition zone can be adjusted in the steps of 0.25. We need to understand the terminology. Dr. Arthur has already explained, but for the benefit, clinical refraction is the subjective refraction or the acceptance. Measured refraction is the topographic refraction or the TMR, and the modified or the hybrid is what you're going to treat. So what does Contoura do? The first step it does is it treats the refractive error. In addition to that, it treats corneal HOA. Now, the corneal HOA will have some effect because of the ablation, and that is compensated by C4 to C12 adjustment. The basic objective is keeping the spherical equivalent constant. The treatment in Contoura is centered on the corneal apex rather than on the center of the pupil. This looks more logical, number one, because it takes care of angle kappa, and number two, because we are taking all the measurements which are centered on the corneal apex. So why treat them on the center of the pupil? Contoura gives more insights, the planning of the Contoura gives more insights into how much cylinder to treat, which is a very interesting thing we have found out. And at the same time, it also takes care of Q value. That means the wavefront optimized profile is maintained, and it also takes care of cyclotorsion where the pupil size becomes important. FDA trial, Dr. Arthur has already alluded to, but the patient satisfaction level was very high. And you can see here, 31% of the patients showed that there is increase in the uncorrected visual acuity. Okay, which is a very significant thing in those days. And all the symptoms, whether light sensitivity, difficulty while driving at night, reading difficulty, and glare complaints, everything decreased. So Contoura is definitely a better technology here to stay, just the way Dr. Arthur has said. And friends, this is just the beginning of the Contoura. We are going to have lots of nice lectures. Thank you for your attention.
Yes, sir.
I'm so sorry. I'm so sorry. Yeah. So after that brilliant presentation, I think we have both topics introduced now, and we throw it open to discussion. And I would like to ask Arthur. You mentioned that Contoura would be great for eyes which met the criteria which the FDA trials were done for, and ray tracing would work better for those eyes which are not the typical eyes. Where the aberrations would be probably would be probably like the outliers maybe. So how would you choose between the two? Do you still perform Contoura, and where do you choose to perform Contoura, and where do you perform to choose ray tracing given a choice?
That's a very good question, Gaurav. So what we did with the controlled launch was we were asked to treat first-time eyes. When you're trying to validate a new technology, you've got to just keep it simple to see does it do the job right. And I think once we get more familiarity with that, what we're going to do is apply it to more difficult eyes, because you can imagine in these really complicated eyes, that's where it'll have a lot of value. So what I have done many a time, I didn't have time now, my time was running out. But what I did do with any complicated eye that I was doing a Contoura on, I would also do wavefront, I would also do ray tracing measurements. And incredibly, every single time I found something very, very similar. So it gives me a lot of confidence that this device is really measuring what we needed to do. And I think what it's going to do, it's going to be a very good repair tool. And over time, it may just be, if it works as well as we expect it's going to, that this is the technology you use. When you can get a scan, which is 80% of the time, you do it with ray tracing. And those times when you can't get a scan, if it's a straightforward case, you might do Contoura, you might do wavefront optimized. If it's a slightly complicated case, you'd go topo guided. But I think there's going to be a place for both. I don't see, the only profile so far that's really been, you can use on anyone, has been a wavefront optimized, but then you're not getting any of the higher order aberrations addressed.
Great, thanks, Arthur. Dr. Ramamurthy, would you like to chip in with your comments here?
Yeah, I think great presentation, Arthur. Always a pleasure listening to you. My question to you is, you spoke about your experience with ray tracing almost a decade back. We have been hearing about it for quite a long time. Actually, more than 8 years back, I bought my first EX500 with the lens star, saying that the ray tracing is just around the corner. Because conceptually, that seems to be the way to go. It seems to take care of almost all the refractive elements involved in the eye. Why is it that it's taking so long for it to be adapted as a concept and be commercialized?
Yeah, that's a really good question. We've had the same question. And I think probably a big part of it is when Alcon was taken over by a pharma company, the emphasis shifts and it's just a little bit different. And now that Alcon is again a medical device company, now suddenly things have caught up and things are going in the right direction. I think that's one of the reasons. I think the other thing is in the background, there are quite a few things that have to happen to make this work. It shouldn't take 8 years, I agree. But they knew they were going to have to switch from a churning system, because we all know, those of us who use the wavelight system, when it works on wavefront, it's phenomenal. But you don't get a very high percentage of patients you can measure on the churning, especially complicated eyes. So they had to change that to a different platform. And then they had to make a decision also, is are they going to make the ultimate device now? Because you can imagine the ultimate device will be an OCT-based device where you can actually measure the epithelial thickness. Instead of taking the literature values, you can measure the epithelium. So that's the device they're ultimately building. And I think this is probably a holding pattern in the meantime, that at least we have something you can measure in one go, do the treatment, expect a very good result, no nomograms, nothing like that. But it has taken longer than expected, there's no doubt. But thankfully, it's here now. And I think we're on a platform now where things are going to start moving.
And you mentioned that even the biomechanics is taken care of. I don't see how's the biomechanics measured and incorporated in this. What's the equipment that you use for this?
No, there's no equipment. The same as the epithelium, there's no equipment. So it's only taken from the literature. So the study done way back in 2009 looked at what the literature said about doing a -3, ablating 45 microns or ablating 100 microns, and seeing what the biomechanical effects were. And the same with epithelium. You expect some epithelial remodeling, and the average of the literature values were used. So there are still some assumptions, even in the ray tracing profile, but in iterations to come, they'll be reduced even more because you'll physically be measuring the epithelium. I'm not sure about the biomechanics, possibly. That's a great question.
Fine. Thank you, Dr. Arthur, for sparing time for us and giving great insights about the ray tracing. Now, he's going to leave us now. It's my pleasure to introduce the next speaker, Dr. Ramamurthy. He requires no introduction, but basically he's trained as a retina surgeon. Versatility made him a very good cataract and refractive surgeon also. He is a past president AIIRSI, and so-called modernization of AIIRSI started with his stint as chairman of scientific committee AIIRSI. Above all, he's a very simple and humble man, and it's always a pleasure to listen to him. So, Dr. Ramamurthy, up to you. Present on treatment plan and workup for a Contoura.
Thank you so much, Vavikar. For this very kind introduction, and thanks to IIRSI, Gaurav and Vavikar for this very pleasant invitation. I think I'm going to learn a lot from this meeting of minds. I think I see wonderful refractive surgeons, great friends all gathered around. This is the right time to exchange ideas and improve upon what we are already doing. Vavikar already gave a nice introduction for Contoura. My premise would be to do a slightly deeper dive and look at the specifics. These are my financial disclosures. I'm a consultant to Alcon as well as Johnson & Johnson. Actually, Contoura happened more by way of an accident. FDA was approached by Alcon for TCAT approval for highly aberrated corneas. And as was mentioned by Arthur earlier, this was already in use right from the year 2003, both in Europe and Asia Pacific. We ourselves had been using it. But FDA wanted evidence that treatment was safe in virgin eyes before they could allow it to be used on aberrated abnormal corneas. So that's the reason the study was initially done. And as was explained, the basic premise is to take the data, the higher order aberration data using the topolaser vario from the anterior surface of the cornea, combine it with a clinical refraction, and use the TCAT software to create an ablation profile which is fed into the EX500 so as to do the treatment which takes care of not just the refractive error but also the corneal higher order aberrations. Basically, what we do is to take about 8 different maps of the anterior corneal surface, and what you look for is to ensure that the mean absolute deviation is in the region of about 0. The K readings, the Q value, and the pupillary diameters all have to be within a particular range for you to get this. Even up to about 0.1 is allowed. All these maps would be looking quite similar, but what's taken into consideration as far as the treatment is concerned is the median value, which is at the middle of all the measurements that has been taken. So this is the topo map which the patient initially has before the treatment. And this is the ideal topography that you would like to leave the patient behind with. And the subtraction of this from this gives you the exact profile of the treatment that's needed for the correction of the higher order aberrations. And you combine it with the refractive error that needs to be treated, that's the subjective refraction of the patient, you get the profile of the treatment that needs to be fed into the machine for correcting the refractive error as well as the topographic abnormalities. So what are the features of the Contoura? It accurately corrects the sphere and the cylinder, corrects corneal irregularities, which is essentially the topo-guided treatment, And it's based on the wavefront optimized platform, so that induction of spherical aberration is also quite minimal. So it seems to combine the best of both worlds, and it optimizes the Q and K value. And what do I mean by this? When you are talking about wavefront optimized treatment, basically what's assumed is a average corneal K of 43 diopters and a Q value of 0.26. But in this particular case, for each cornea, it's specifically measured, and that's what is it taken into consideration when we define when we decide upon the profile of treatment. So it becomes a far more accurate. And again, as was mentioned earlier, the treatment is centered on the corneal vertex, which corresponds to the visual axis of the patient, because of which the pupil centroid shift ceases to matter, and there's an inherent cyclotorsion compensation, which seems to be the most physiological way to do the treatment. Looking at a couple of examples, this you can see is a walk in the park case, where you can see that there's just a minus 2.75 diopters of spherical error. And this would obviously do extremely well with a wavefront optimized treatment. And this is exactly the profile of treatment that would be required to treat this particular cornea in case we are not addressing the higher order aberrations. But when you want to address the higher order aberration, this is the treatment profile that's required. And you see this is a bimodal treatment. This is the area of elevation, which is specifically handled. And this is the area of relative depression. And you have a hyperopic aberration that is taking place over here. And this, when it's combined with the wavefront optimized treatment for the basic refractive error, this is the final profile of the treatment that's delivered. Just to show you more clearly, this is the manifest refraction that's fed into the machine. This is a height data that you for the higher order aberration correction on the corneal surface, and this is the final treatment plan that emerges. And it's always important to make sure that Contoura and the wavefront optimized must closely match, as you can see in this particular case. In case they do not match, then you need to relook at it, or maybe abandon Contoura and go ahead with the wavefront optimized treatment. You can see the fellow eye of the same patient. You can see the combination of the manifest refraction data of the higher order aberration and the treatment data that's applied for the correction of the refractive error with the corneal higher order aberration. So essentially, to get FDA approval, this was the study that was conducted by Alcon in 9 sites, 212 subjects, 249 eyes were corrected, up to a minus 9 diopters of spherical error, and astigmatism of about 6 diopters, and basically 3 diopters was the average astigmatism which are treated. As was mentioned earlier, Alcon themselves are surprised with the kind of results they were able to achieve, in the sense that 93% of the patients achieved 20/20 or better, 65% achieved 20/16 or better, and 34% of the patients achieved 20/12 or better. And 31% of the eyes had 1 line or better postoperative uncorrected visual acuity compared to the preoperative best corrected visual acuity, which was not being achieved by any other platform so far. And even more significantly, when you talk about quality of vision, there was a statistically significant improvement in postoperative reduction in glare, halos, night vision difficulties compared to the preoperative measurements. And as far as the subjective evaluation of the feeling of the patient is concerned, almost all platforms that are being used, whether it's wavefront optimized, whether aspheric neutral or smile, basically the quality of vision definitely tends to deteriorate compared to what was the patient preoperatively experience. And the fact that this offers somewhat of a better quality of vision compared to what was the patient was having preoperatively came as a pleasant surprise. And it initially, when we got this Contoura installed about 6 years back, we thought that we would exactly apply the criteria that the FDA results applied. And we were also quite pleasantly surprised to see that 97.5% of our patients, initial 112 eyes, achieved 6/6 or better vision. An improvement in postoperative uncorrected visual acuity compared to preoperative best corrected visual acuity was in 31% of eyes, which was almost comparable to what was achieved with the FDA results. We thought that we have really hit the holy grail of refractive surgery and we are going to get repeatable results. But that is not to be, because when we widened our scope of studies and did 100 patients, 200 eyes, 1 eye contralateral eye study, which got published in IGO in 2018, One eye received wavefront optimized and the other eye received Contoura treatment. Mind you, these are all normal run-of-the-mill cases, not aberrated eyes, but myopic refractive errors or myopic astigmatism patients. The visual outcomes are quite comparable. 95% of the eyes achieved uncorrected visual acuity of 6/6 or better by using the wavefront optimized platform, and using the Contoura it was 100%, but this was not statistically significant. When we had a deeper look at the induction of higher order aberrations, there was a little less horizontal coma and trefoil that was induced with the Contoura platform compared to wavefront optimized, but this was again not statistically significant. So our conclusion was that though both the platform worked quite well, there was really no great clinical benefit when we use the Contoura in the contralateral eye compared to wavefront optimized in the other eye. So why the difference between the FDA and our initial results compared to when we did a larger study? It was essentially the criteria for inclusion as far as Contoura was concerned was extremely precise in the FDA and initial eyes also. The cylinder had to be less than 0.75 difference between the manifest and the measured being what you get from the topography. And the axis had to be within 10 degrees when the cylinder was less than 1.75 diopters, and less than 5 degrees when cylinder was more than 2 diopters. So in reality, as was already mentioned, only 10 to 20% of the eyes will meet the FDA criteria. So essentially in the FDA studies, and as far as our initial eyes, which the 112 eyes that we treated adherent to the FDA criteria, they had minimal or no topographic abnormalities. And when minimal topographic abnormalities are there, manifest and measured are likely to be almost similar. And maybe these are not the patients who are going to benefit maximally using a topo-guided treatment. So in real life scenario, if you use a FDA criteria, only about 10 to 20% of patients would benefit from a Contoura treatment. So then came the idea from John Kanellopoulos, who said it is essentially the defective eyes which have abnormal corneal topography, where the measured and the manifest refraction are quite different, who are likely to benefit the most. And he went ahead and treated the eyes using the topography modified refraction, where he ignored completely the refraction, the manifest refraction, and go entirely by the axis and as far as the magnitude of the cylinder that was there on the topographer. He claimed his results were quite good. He claimed superiority in uncorrected distant visual acuity, corrected distant visual acuity, residual refractive error, residual astigmatism, residual higher order aberration, and contrast sensitivity. But unfortunately, his results could not be replicated both in Europe as well as in Asia when some of us did these studies. And mind you, it also requires a great jump in a great leap of faith to go ahead and adapt this principle. You can see that the differences that between the manifest and the measured could be as high at 1.83 diopters, as you can see over here, and the difference could be as much as 70 degrees in axis. So obviously, just to ignore completely what the patient accepts and go ahead and treat only based upon the topographic manifest cylinder is something that was difficult to digest. And that's why that's the reason behind this is basically the assumption that Kanellopoulos does is that the entire astigmatism is on the corneal surface. But you all know that it can be on the posterior corneal surface, it can be in the lens, and it can be in the retina also. And this could even be counteracting each other or adding up to each other. So it's essentially assuming that all the astigmatism is from the anterior corneal surface, and plugging in that data alone might not be the right way to go. So the mid path came about where we thought that we could go somewhere between the manifest and the measured. Basically, in this, the premise is to, as far as the spherical error is concerned, is the measured which is taken into consideration. The axis of the cylinder is from what is from the spherical error that's corrected is from the manifest, what the patient subjectively accepts. The axis of the cylinder that's corrected is from the measured, which the topography gives you. And in case the refractive cylinder is more than the measured cylinder, then what you do is to basically go ahead and feed in the measured cylinder alone, and so as to ensure that the spherical equivalence is maintained. You go ahead and reduce half the cylinder. You can see it's 1.75 is the refractive cylinder. The measured is 0.75 cylinder. So you go ahead and feed in 0.75 cylinder, and this half a diopter difference is compensated in the sphere, so that the cylinder essentially comes from the topographer. In case the refractive cylinder is the refractive, sorry about that. In case the refractive cylinder is less than the measured cylinder, in that situation, basically what we do is to go ahead and feed in half the difference. You can see -1 diopter and -2 diopters, and you are taking in -1.5 diopters as a cylindrical correction. And quarter of the difference is what is subtracted from the spherical error, and that's the reason that you have -2.75 diopters. So basically what you ensure is that spherical equivalence is maintained. That's if you have -3 with -10 diopters, and your refraction is -3.5 diopters, and here it's measured, and as far as the modified is concerned, again what you're corrected is -3.5 diopters. It seemed to be a compromise solution. That's what's recommended by Alcon today, but it does not completely stand to logic, and that's the reason that we are looking at better iterations of the treatment becoming available. FourSees is something we look forward to hearing from Mark Lebanoff, who's going to be coming up right next. I believe that I have basically laid the foundation for him to take it forward. Ray tracing is another concept which conceptually sounds the right way to go, and Arthur Cummins has extensively handled it already. And that brings me to my end of my talk, and thank you so much for your attention.
Thank you, Dr. Ramamurthy. It was an excellent talk. Dr. Nitin, would you like to elaborate on the treatment plan?
Thank you, Dr. Vavikar. As usual, Dr. Ramamurthy's talk was a splendid talk. In fact, every time I hear him, there is something new to learn, very explicitly and well explained. 2 points I would just like to add, especially for the people who are starting Contoura new, is first and the foremost is being a topo-guided treatment. There's a lot depending on the topographer. So it is very important that the topographic readings, the topographic findings are revalidated every time. That means you validate, because garbage in is garbage out. So it's important to go back to the raw data. And once you see the camera view of a topologizer vario, you would see the red and the blue lines. And it's very important to see where these red and the blue lines are discontinuous. If they are discontinuous within the ablation zone, within the 6.5 millimeter optical zone, then these readings are not good readings and they should be repeated. Probably in case there's a dry eye or something that needs to be addressed. The thing number 2 is in case the manifest, there's a lot of difference between the manifest axis and the measured axis. It's important to again re-refract these patients, because very often we take up the patient in the OT and do not re-refract them. The third point is that it's important that in every case you make the target refraction 0 and actually visualize the Contoura treatment, what it would do with the refraction made 0. So you would know what are the higher order aberrations being corrected. And when you see the Zernike's polynomials, like Dr. Vavikar mentioned, you would definitely want the C4 and C12 to be equalized. But it's also important to note what are the other higher order aberration, that is the C6 to C9. So these are the things. In case you find the C6 and between C6, C7, C8, and C9 values to be significant, these are the cases which should definitely do well with a Contoura treatment.
Yeah, excellent point. Excellent point, Dr. Nitin. We are going to go into that territory soon. But I have a question for Dr. Gaurav.
Yeah.
So, Dr. Gaurav, you think that now there is no scope for wavefront optimize and Q Lasik, FCAT Lasik that we are all talking about Contoura?
No, in fact, that's a good question, and in fact, I think that's a question on everybody's mind. That once we have newer technologies come in, does that replace everything? That's like saying that with Smile coming in, have we lost LASIK and PRK and everything else that goes with it? So I don't think that's ever the right answer, because when you have more technology available and newer thoughts, I'm sure they're applied in different ways. I still love to do wavefront optimized, and there will be indications where you'll want to do all the what suits the patient best. So I think you have to match it. I would have loved to hear from Dr. Dhami, who has a lot of experience with the FCAT, and he continues to use the Contoura, and I don't think he's been able to join us. But here maybe your question may be better answered by Rohit, who has done tremendous work on all three, the wavefront optimized and the FCAT and this thing, before we go to Mark's talk as well.
Yeah, Dr. Rohit is here.
Yeah, I'm here.
Please.
I have that whole thing in the presentation, Dr. Gaurav. Is it okay?
Great. Absolutely. We'll listen to you during the presentation. So I think, the message is obviously clear, Dr. Vavikar, and we should please go ahead and, I think everybody is looking forward to hear from Mark for his presentation, because that will help us, plan our treatments even better. Yeah.
Yes, absolutely. So our next speaker is Dr. Mark Lobanoff. He is founder of FourSees and director of Refractive Surgery Services at Minnesota. He is an accomplished cataract and refractive surgeon and developed special interest in Contoura. The researcher in him sought to make the Contoura calculations easier, and he came up with a software called FourSees. Now let us hear from the horse's mouth what this FourSees is all about. Over to you, Mark.
Thank you so much for allowing. Can you see my screen?
No, we don't have your screen yet. Yeah, and we can see that you're trying to do that from your car or something, and it's quite amazing. Yeah. You've come out of work, is it?
Yeah. 1 second. Yes, I'm sorry about that.
Thank you so much for taking out time. Yeah.
Best way to share policy.
Mark, we are losing your voice, and we still don't have your screen. So.
Okay. Give 1 second here.
Sure.
Trying to get better coverage. I apologize.
That's absolutely fine.
Okay.
Yeah, we have your screen now. Perfect.
Can you see my screen?
Yes,
Oh,
it started coming on. Yes. Wonderful. You just need to go to slideshow maybe and maximize.
So, very good. Okay, so this is a discussion on the FourSees analytic engine, and Dr. Ramamurthy did an excellent job outlining the difficulties with the FDA study. In the FDA study, no fewer than 3 cornea experts looked at every cornea, and only perfect corneas were allowed into the study. And this was one reason why the results from the FDA trial were so good. My data in orange, Dr. Kanellopoulos' published data in yellow showed that neither of us achieved the 2020 level, treating off the manifest refraction as was seen in the FDA, and we definitely fell behind at the 2015 level. As Arthur Cummings and Dr. Ramamurthy outlined, strict FDA criteria for Contoura when treating off manifest refraction, because very often the axis of astigmatism from the manifest refraction and measured anterior corneal astigmatism differ. Only 10 to 20% of patients will meet this strict criteria. Kanellopoulos came up with TMR, where he suggested we trough the full measured slender amount and axis. As was stated, this doesn't improve at the 2020 level. So did Dr. Kanellopoulos's, but we still fell behind at the 2015 mark. So really what was needed was a new approach, an analytical mathematical approach. We needed to be able to predict the effects of topographic treatment, treating topographic irregularities, and we need the ability to predict significant contributions from the post-corneal astigmatism and any lenticular. So again, what the software does is it uses geographic imaging software to identify these areas of elevation. It assigns them a refractive value, and it gives them a vector. There is a directionality to the refractive component here. It takes a vector for the anterior corneal astigmatism, a vector for the posterior corneal astigmatism, and each topographic area is given a vector as well. This is not a nomogram. It's far more advanced. It's very fast. Here we see a calculates. The software is analyzing the topography, calculate treatment. Now, what's important to know is Wavakar told us earlier, we need to balance out the Zernike higher orders, some of the Zernike coefficients to get the correct sphere. FourSees does that mathematics for you in less than 2 seconds. It's also programmed to the sphere, so you have correct sphere. It's adjusted for any cylinder fraction at the 2020 level. However, notice what happens at the 2015 or better level. FourSees vastly outperforms using manifest refraction as the method for calculating the treatment. So we believe that FourSees really is proving that it gives the best results for calculating Contoura. It makes the calculation much easier for the surgeon. And thus far, it's been very well received. And I just want to say thank you guys, and I appreciate you putting up with my poor internet connection.
Thank you, Mark. It was a really nice presentation, learned a lot. It's a very difficult topic, but you made it really simple. There's one question. How do you measure posterior corneal astigmatism?
This is where we use the shine fluid device. So we utilize either Pentacam or Galilei G4. The shine fluid device gives us the ability to look at the posterior astigmatism. Although not perfect, it does help us achieve that variable. This is very important because oftentimes the posterior corneal astigmatism, it's always assumed to be 90 degrees away from the anterior corneal astigmatism. But what we have found is that that is not always the case. And so it is important to know the magnitude and the direction of the posterior corneal astigmatism. Consider that in the calculations. FourSees pulls that data out of the G4 Pentacam automatically and takes that assessment into account.
Excellent. Dr. Neeta, are there any other ways of measuring posterior corneal astigmatism? I am referring to IIRSI 700. Any experience you have?
Yes, I had met Dr. Mark, and along with him, we are carrying out a study which is ongoing, where we are putting the posterior cornea data from the IIRSI and seeing how the results are. What I have found different from what Dr. Lobanov has shown and what we end up doing here is there they have the Pentacam. Here, like my center, there are centers where we don't have the Pentacam, we have the oculizer from EX along with the wave light machine, and there the data is not picked up automatically from the scans which are sent. So it's very important that we feed in the correct data, because that is how the software would help us in calculating. If we don't put in the correct data of the posterior cornea, that is when the FourSees may give us a signal that it's not matching, and you go ahead with WFO just because we have not put in the correct data. So yes, the IIRSI 700, whatever I have done so far is looking very encouraging, and I'm waiting for Dr. Lobanov to make changes in the software, if at all needed, for us to use it more and more, because the posterior cornea data from the OCT part, the swept source OCT part of the IIRSI 700 is definitely pretty good. I'm sure all of us as cataract surgeons have also seen that.
You bring up an excellent point too. This was, when do you use wavefront optimized? And one of the things I built into the FourSees software is that it advises you if this particular eye is not going to do well with Contoura, and give the surgeon a warning. For this eye, we suggest that you convert to wavefront optimized. So FourSees is trying to keep you out of trouble. As Nita very acutely pointed out, FourSees also looks at the data that you're entering. And if the data does not look correct, FourSees will warn you and say, please go back and check this data. Make sure the data from the IOL master or the Pentacam is being entered correctly. It keeps you out of trouble. It prevents you from making mistakes. The final thing I'll add is that Dr. Cummings said that later they want to, for the new ray tracing, bring in OCT epithelial thickness mapping. We're already doing this with FourSees. So FourSees is now being programmed to pull epithelial thickness data into the software for analysis.
Great insights, Mark. Dr. Ramurthy, have you been using FourSees? Your comments, please.
I also had an opportunity to interact with Mark, and it was a great learning experience. We have been using both Contoura and FourSees, and actually we have been doing a comparative study also. And our initial results are showing that the FourSees performs slightly better. My question to you, Mark, is one thing which bothers me is that one of the key factors we take into consideration is the subjective refraction. And unlike what we measure with all the different instruments, where there's a lot of accuracy that is there, when you the subjective refraction is something which an experienced optometrist gives me, and a 0.25 diopters of refractive error or a shift of 5 to 10 diopters per cylinder, because it depends on the acceptance values of the patient also, plays a major role. I mean, is there, in this respect, I feel ray tracing is something which takes an objective view of entire data, while here this, in your platform, the subjective refraction plays a major role. How do you compare these two?
That's a very good point. And someone mentioned earlier, garbage in leads to garbage out. Every refractive surgery that I've ever done begins with a good base, and that good base is a solid manifest refraction. It is subjective though. And so in the software, FourSees does rely heavily. One of the problems with the ray tracing platforms that they have not quite outlined yet though is that it's very dependent on pupil size. And what we learned from Wavefront Guided is that pupil size, or the pupil became more mydriatic, it really dramatically changes the wavefront you're planning to treat. And because the ray tracing depends so heavily on the wavefront biometry, biometry is a great addition. The tomography is an important addition, but it also does rely heavily on the wavefront, which can be variable based on pupil size or accommodative effort on the patient's behalf. So every platform does have some weaknesses and some strengths. I think what's great about Alcon is they're bringing this broad array of technologies that we can use. And as surgeons, we have to find the right technology. But yes, long answer to your question.
Sorry, we lost you the last bit.
Yeah, we lost the last part of your sentence.
He said that manifest refraction is very important.
It's key.
That's
Yeah.
Key.
And I feel to every refractive surgery, I think as refractive surgeons, I think we all know that manifest refraction is probably the first and most important thing. Then we can only start customizing beyond that. But I had a question that, Mark, you said that the lenticular astigmatism was the only variable which we actually didn't feed in. Why don't we do that from some device like the eye trace or the OPD scan and try to separate out the corneal from the other aberrations and maybe try to use that as well?
I have yet to find a device that actually measures particular astigmatism. There are devices that will look at corneal higher order aberrations. There are devices that look at total eye wavefront higher order aberrations. I have yet to see a device, and you guys could teach me, but I've yet to see a device that can accurately, repeatedly measure the true lenticular astigmatism. Therefore, we have to.
I agree on that. Yeah, until we have a device which actually does that well, I think we are still with what we have. So, over to you, Vavikar.
Yeah, nice discussion. Very good points brought about. Now, we have, for the same problem, many times we get different solutions. And we have Dr. Nikhil Balkrishnan from Narayan Netralaya, young and dynamic, is going to talk on behalf of Narayan Netralaya, that they have also developed a different method of handling the contract calculation. Over to you, Nikhil.
Thank you, Dr. Vavikar sir, Dr. Luthra sir, and IIRSI for allowing me to present. Dr. Rohit Shetty sir for giving me this opportunity to present our work on this platform. So basically today I'm going to be talking about the 3Z software. It's a software which makes Contoura simple. So we developed this 3Z nomogram. This 3Z stand for the Zernike's pyramid, the zero rule, and the zonules. Now, when we come to the Zernike's pyramid, the basic plan here is to find out the aberration profile. So which we can either get from a topographer like a pentacam or from an aberration like a ray tracing aberrometer like the eye trace. Now, the zero rule, like already spoken before, it is very important to modify the refraction to zero and then see what the ablation profile is. higher the ablation profile, which would indicate increased higher order abrasions in this patient. And finally, coming to the zonules. So from the eye trace, we can come to know the internal, which is basically made up of the lenticular abrasions, and also the O series T, which gives us the dynamic accommodation. So basis on this, we divided all the patients who are undergoing Lasik at our center into 3 groups. The group 1 consisted of patients where the subjective cylinder and the measured cylinder were more or less equal. Group is on the eye trace, first by showing the patient a target at 20 feet per distance, at 60 centimeter for intermediate and at 40 centimeter for near. And like we see, both for distance and for intermediate, across all 3 groups, you got really good results. There was a 0.1 for the logmar for near in group 3, which can be attributed to the lenticular component, which was compensating. Now, this is the stats, the post-op distribution of the spherical error. Now here we see, as we go across the 3 groups, similarly, as we go from distance to intermediate to near, there is an increase in the sphere, the residual spherical error, which is obviously because as we go towards the near, the patient starts accommodating, and that is why we found these results. Whereas in the cylinder, across all 3 groups, even as we go from distance to intermediate to near, the results were uniform. Now going to the depth of focus. So as I said, depth of focus is very important. Patients nowadays are very, need this depth of focus, especially the young professionals nowadays. And therefore we did a study where we compared the depth of focus in age-matched E-metropes, patients undergoing SMILE and PRK, and we published our results. And the results show that the Lasik, the patients undergoing Lasik, in our case where we did 3Z, had the closest to the normal matched E-metropes. This, as I said, is very important in young professionals nowadays, in IT groups, etc. So further, the aberration profile, we found the aberration profile, the change in aberrations, that is from distance to intermediate and intermediate to near. We found an increase in defocus, again attributed to accommodation of the patient, and lower order aberrations remained uniform across all the 3 groups. So what are the advantages of the 3Z software? One, it is very
with focus lens, particularly one with spherical aberration correction. I thought this would be a standard. I would use it and I would find no astigmatism. Most patients with the still focus IOL have some lenticular internal astigmatism because of the concept of some lenticular tilt to that IOL. And if the spherical aberration of that lens is slightly off the visual axis, that too will lend itself towards some astigmatism internally. This has been found in the ray tracing platforms as well. One of the key aspects of the ray tracing platform is it does look at lenticular tilt with that biometry. So yes, lenticular astigmatism plays a role. In some cases, it can be, I had some outliers that are 2.5 diopters of astigmatism from their natural lens. I did a clear lens at me, all that astigmatism disappeared. So yes, it must be considered, and in some patients, it's quite important.
So like what 3Z software has, they know that this may be a lenticular astigmatism and they recommend wavefront optimize. So you already alluded to this point before, but do you have any warning kind of a situation in FourSees where this might be lenticular?
Yes, so this is where we differ a little bit. I was fascinated by his presentation. It's a great approach. I applaud him for his work. FourSees took a different approach, and we decided that that lens is going to be in the patient for many years. And if there's lenticular astigmatism present, we put that into the calculations and we place a treatment on the anterior cornea that counterbalances the lenticular astigmatism. Because every patient has some lenticular astigmatism, the way that we try to optimize our treatments is for that. And so using this, we can now treat up to 95 to 97% of our myopic patients with FourSees Contoura. The amount of patients that are recommended for wavefront optimize are quite low. But a different approach is, you might say, well, I don't want to account for the astigmatism, convert to wavefront optimize. That is a valid approach. I prefer to treat as many patients.
Very good. Interesting. Very interesting thoughts. Dr. Nitasha, you have been using both the platforms, 3Z and this FourSees. Can you give some comment?
So actually my journey in Contoura before Contoura was totally motivated and inspired by Dr. Rohit Shetty before it was called Contoura. And that is how I took an interest in topo-guided treatments and astigmatism management for cataract. And I was privileged for him to give me the 3Z platform when he started with it. And what I found is it was very simple to use because it was divided into 3 groups and it did not need too much of equipment, which would need data to be put in. The chances of errors put in were less. And we knew the group where we had to be cautious and have our antenna up so that we could separate out those patients as the patients who would maybe give us problems later on and take care of them and analyze them better and do it. But definitely very nice to work with.
Can I add one point here?
Yeah, please.
I think we should ask this to the panel and also to Dr. Mark Lebanoff. What we found is in our population, we are studying close to around 500 of eyes, patient with refractive, and we looked at the corneal, we're looking at multiple things, including corneal volume. The geographic way in which a cornea is structured, we are seeing the posterior corneal astigmatism in our population, in a healthy population, is very, very, very small. I would request Dr. Ramurthy sir and Dr. Neeta ma'am and everybody else to go back and look at your posterior corneal astigmatism. See, what Dr. Mark says is perfectly right, but we are looking at 2 geographical difference. Our ACD is smaller, biomechanics is different, corneal volume is different, our thickness is different, and structurally our corneas are not the same as what we see from a different geographical thing. So one thing we have to really look at it when you look at any posterior corneal astigmatism is geographically there is no data from an Asian group on PCA. I don't know, I'm not aware of it. So it is a good way, Dr. Mark, I think it's a good one to look at difference in PCA versus different geographic areas. I think there will be definitely a difference in the way a PCA is, because in our data, the one reason why we decided to use the total corneal power is the difference was just around 0.2, and we would hardly get a PCA which is quite significant. And I would request my other colleagues in this group to go back and look at your data. I think you'll be surprised about this new find.
You make a great point. And one of the things that you'll find is you use, as I've used and used FourSees, the majority of eyes do not have very large topographic elevations on the cornea, maybe 8 microns, 10 microns high. The problem is occasionally you'll have an outlier that has 16 microns of height or 20 microns of height. And so then with those corneas that have these higher aberrations, it becomes more important. For lower aberrations, 8 microns to 10 microns, the waveform optimized might give a equally good Snellen acuity, be different. Because you're treating these topographic raised elevations, you're treating the higher order aberrations, you tend to get a better quality image. This is hard to measure, but we do see it in our patients. But you're right, I think geographically and just genetically, different populations will have tricks.
Just one question. I was quite intrigued by your reference to the fact that the depth of focus is much better with your platform. I mean, that's not something usually we look into, or though it's extremely important when we are talking about laser vision correction. How do you think this is improved? Is it because of some kind of a spherical aberration being left behind, or how is it? How is the depth of focus better?
So for me?
Yeah, either one of you, Nikhil or the boss himself.
Nikhil will answer.
So, sir, basically, if you look at our results also, there are cases in which we have left behind a little bit of cylinder. The cylindrical correction, we have left behind one. Because of that, we've seen that patients are getting better vision. We've got a lot of patients reaching even 20 by 16 vision in most of the cases. When it comes to depth of focus, yes, we've seen that throughout in our software that because the small amount of spherical correction that has been left behind, the patients are getting better depth of focus in all the cases.
So I think one of the reasons could be if we are trying to negate everything of the cylinder from your cornea, your depth of focus always is going to be taken by the lens. So the lens starts pseudo accommodating many times. So a 0.25 or some kind of that could be one of the thing. And maybe you are correcting unwanted aberrations, but keeping the wanted aberrations like spherical aberration intact. We found that the amount of spherical aberration corrected versus this with the wavefront optimized was completely different. So that means you're keeping what is necessary, and probably that would probably why it's giving a depth of focus. And the second is lot many people measure depth of focus as a routine measurement. But we've been using this because a lot of young people who come to you for refractive surgery need more of depth of focus than a 20/15 vision, because they're not going to fly a plane. They're interested in sitting with your computer and also looking at a distance of 6 meters. So I feel the next generation of technology should aim at giving a perfect depth of focus, because in terms of how evolution is, we are going back to sitting and watching and also looking at something which is away. So I think the real distant vision and N6 vision may not be the real way of evaluating an outcome.
I have a
And
question.
I would just say that when we did some TMR studies, you can make a cornea perfect. You can leave the anterior cornea with 0.0 diopters of astigmatism. It doesn't mean that the patient will not have astigmatism on their manifest refraction. As you just said, because of the lens. It often is advantageous to leave some astigmatism on the anterior cornea to counterbalance the astigmatism that may be in the lens. And this is what, and probably what's allowing you guys, that's great work to increase that depth of field. The other thing is by correcting the Q, by modifying the Q, spherical aberration is really important for increasing depth of field. And so one of the nice things about Contoura, being able to modify that Q factor, leaving or creating some spherical aberration if you
Dr. Arul wanted to ask something.
Yeah, I have Nikhil, one question and one observation. As a standard, I've been treating all my LASIK and SMILE patients by leaving behind a 0.25 spherical and a 0.25 cylinder as a routine. And in the long run, when these patients come back to you later on, even 10 years or 15 years later, when they become presbyopic, you find that they don't need presbyopic correction right up to 48 or 50. So that's one important factor that has really been noted by Nikhil, and we all should think about following it. I have a question to Nikhil. Your presentation or your study said about the manifest refraction and the measured astigmatism only in the quantum and not in the axis. So when you have a difference in the axis, what did you do, or did you not take those patients into the study?
So we studied both the quantum of the astigmatism and the astigmatism axis too. So where we saw there was a difference in the axis. So when we found out what was the reason for it. So when we attributed it to higher order aberrations in higher order aberration, that is a second group of patients which had higher corneal distance, we use the Contoura platform there, and we treat the axis there based on what the topolizer gives us. Whereas when we are doing it in group 1, we go ahead in patients in group 1, we basically treat the manifest refraction in those cases directly.
Okay, thank you.
Yeah, very good. Dr. Gaurav?
Yeah, so I think we've had a fantastic discussion on both the softwares, and I think it makes a lot more sense. I've been using the 3Z software, and I've enjoyed using it, and I would love to lay my hands on the FourSees now and maybe try to use that, and it looks so interesting as well. So, Dr. Amurthy, you want to say something before we go on to the next one?
Because apart from what has been discussed, my contention has always been, whether it's with the lens or on the cornea, you buy depth of focus using the currency of contrast. So as Arul was mentioning, minus 0.25, minus from 2.25 cylinder, etc., leaving behind, maybe a good idea for a 38, 39-year-old. But I have 20-year-olds who come here with the small refractive error, 1969 pass, otherwise 66. I even had to do enhancement for such small powers. Even though I try explaining to them, this might help you later on, they just are not willing to accept it. So I think, especially those under 30s, it's very important to get spot on emmetropia. And in case you are able to do that, and at the same time, as Rohit said, are able to get some amount of depth of focus, which will serve them well later on, that would be a great way to go.
Yes.
I completely agree, actually,
Yeah,
Dr. Ramamurthy,
agree.
because some of these young people, they will be very fussy about even those small refractive errors, and they're leaving behind something would not be a great idea. So I think now I have the privilege of introducing my dear friend Professor Rohit Shetty, who's Vice Chairman of the Narayan Nethralaya. Uh, he's been an amazing inspiration for all of us in India with the kind of work that he's doing at Narayan Nethralaya. He's been a mentor to so many fellows, and the kind of scientific work and the research work. I've visited the labs at Narayan Nethralaya. Uh, they're doing amazing work. And personally, when stuck in crazy situations, Rohit has always been of great help in sorting out. He's always ready to help all of us when stuck, and comes up with great solutions. So I think Rohit is appropriate subject for you to speak on today. Controversies in Contoura and Schwinn. He has great experience with both the platforms, so he'll be the right person to talk on this topic on topo-guided surgery and the controversies with both the platforms. Rohit?
Thank you, sir. Am I audible?
Yeah.
Perfect. Thank you, sir. Thanks for this introduction, and thank you and Dr. Wavekar, sir, and IIRSI for this opportunity. These are my financial interests. The reason why we are talking about the new way of technologies is I think it's explained by this picture. There'll always be somebody who's going to charge you less. But if we charge you less, you'll always get a picture like this. And so because people now, especially refractive surgery, has got so much of competition to reach the peak and to be always remain in that peak. So it's very important we understand all these technologies. Many of this has been explained, so I'm not going to go. I'll be very quick. I'll discuss only things which we have not discussed in the previous speaker. The challenge is always about the cylinders. I think Nikhil has given a very nice explanation about one, the cylinders are measured, and what is actually given by the patients are different. Because when you look at the cylinders, it's a mix of aberrations and it's a mix of your curvature, and that's what makes up the cylinder. And also you add up everything, this becomes your corneal, and then you have the lens, which is a different composition altogether, and this is what you get is as a final one. We end up with these kind of topographies, and we don't see a lot of things. We don't see an epithelium, we don't see the aberrations, we don't see the lens changes, we don't see how the whole planning is, and we don't see the whole concept about the lenticular aberration or astigmatism, which has been discussed. There's many things we miss when we just look only at your topography. Uh, this case is again, Nikhil has explained, but I'm just going to go into very brief into this. This is what I mentioned by the group 1, where you have the other aberrations are perfect, but still your quality of vision is bad. And these are your good ones. And what's important here is, this part has already been covered. What I'm interested in this, post-operatively, you don't induce anything. Is no induction of spherical aberration. And this answers what Dr. Ramurthy said. Why do you have a depth of focus? Why do people have, when I do a Contoura on a person who's 42-year-old, even I don't do a monovision, still he has a good reading vision. He doesn't lose his ability to read. That's because that you are not unnecessarily inducing more SA to that patient. And this is a patient with the group 2, what we call it. And you can see that's a lot of coma out here. And when you treat the aberrations, and you see that the entire coma is gone and is not induced any aberration. So these are all very important factors. And this is again a patient with a very high level of lenticular aberrations, which is given by the defocus. All our other aberrations are normal. And this is very important that we have to be very careful in treating this. Mark said that he would use his own way, and we use, in this case, we don't want to burn ourselves, so we go into the wavefront optimize. But one very important thing is, which is for all refractive surgeons here, when you see a lot of lenticular aberrations, first thing you have to do is get an orthoptics evaluation done, because invariably this patient has binocular issues. They have orthoptics issues, and these are the patients who come back to you unhappy. And this is why it happens when you have a lot of accommodation. You could have a divergence, convergence of fusional version dysfunctions. And these are terrible to treat because these patients are very unhappy. They say that they just can't focus. Sometimes you retreat them, you do multiple things. And this is extremely difficult to do it after the surgery is done, because you have to give them a very long amount of exercises and all these changes. The second controversy is always about epithelium. There are different ways of understanding the epithelium, and we've done some work. But one very important tool, which I have no financial interest in this, but the CSO has come out with tool called as MS39. What it does is it gives you a corneal maps, the pachymetry, and it gives you an anterior elevation. And this is very important. It gives you without epithelium, and this is epithelial map, and it removes the epithelium. This elevation here is without the epithelium, and this is the posterior elevation. So it's everything comes in one maps. So this is what I said: the epithelium, the stromal thickness, and the posterior thickness. Why it is important here is it also has a unique map of looking at the Zernike from the epithelium. This is important here. It's an epithelium Zernike. It's not. So that means it looks at how irregular is your epithelium. Now, why is it this important? It looks at a 5 millimeter zone. You can see here is that the spherical average, the spherical power from the epithelium is around 0.25 diopters. There's no cylinder in this patient. In this patient, this is a keratoconus picture. What it's saying is that the cylinder in this patient could be around -2 diopters, which is coming from the epithelium. So it is very important for us to understand that epithelium also plays a very important role in your understanding of your cylinder, of your topography-based cylinders. So let's look at this. This is an epithelial irregularity. And you can see this is the thickness profile of this. And see here, the patient has a 0.95 diopters of change from the epithelium. I'm talking about the epithelium here. I'm not even talking about the whole cornea. The whole cornea is maybe completely different. And look at this high level of coma out here. Look at the trefoil here. And this patient is normal. There's no cylinder, no aberration. So that means an irregular epithelium like this has a huge impact in the kind of treatment you do. For example, if you're doing on this patient with a -3 diopters, and if you have an irregular epithelium here, and this is from the stroma, which is normal, that means it's only the epithelium issues. The stroma is normal. All greens are normal, like any of your other. And if you have this kind of a picture, and if you have an irregular map, now you use the best of software, the beautiful software what Mark has mentioned, or the 3Z. It doesn't work because ultimately it's your epithelium which is playing the devil here. So because what we are trying to measure is from here, what we should be measuring is from here, and that is what MS39 is giving. It's giving your measuring here, but at this point of time, we are not able to take this and treat. We should be actually treating this, and we are treating this. And we know that based on this, we know that we have actually a 0.95 diopters of around cylinders related to this. And this is why sometimes our results don't go. So very important controversial point, what I'm trying to say here is epithelial maps has to be looked at when you are doing these kind of treatments, because if you have a epithelial irregularity like this, it's going to be tough. So that is very, very important. And this is again an epithelial and stromal maps out here. Dryness is one of the major factors which changes the epithelium, and this is why Contoura in a very dry patient with a very poor epithelium can be extremely controversial. And that's something which all of us have to really look into this. And we did some confocal nerve studies. This is OSDI, which is normal. This is mid, and this is bad. I can see that this is healthy nerves. The nerves are not good, and here you have a lot of dendritic cells here. They're not the good health, and you don't want them to be there, and they are the ones which creates problems. And this patient was a contact lens intolerant patient, so you wanted a surgery. And at that point of time, we took all kinds of patients, whether they've had irrespective of nerves, because it was anyway contact, and we didn't want to say no to any patients because we wanted to see what happens. Look at the confocal nerves. Look at the epithelium. Sorry. This is decent. There's only around 2 microns. There's so much of difference here. And look, as the nerves get worse, the epithelium also gets worse. And you do all the procedures. What really happens? This is interesting. The nerves heal faster here, very slow and absolutely chaotic. You don't see the nerves. Compare the nerves of the same patient. These are more dendritic cells, more unhappiness, and always complete. This patient used drops for 6 months, still continuing the drops. Now, interesting point is what happens to the epithelium. Look at the epithelium. A healthy one, decent, and bad. And this is what happens in a patient who comes back to you with glare, halos, and you do a retreatment, you lift the flap, again it gets worse. And entire astigmatism coma is coming from the epithelium here. And again, there are a lot of issues with treating the aberrations. This is what I mentioned: when you don't have a depth of focus, when you want to treat everybody, too perfect optics is not good. This is one of the patients. This is not Contoura, it was Smile, but doesn't matter. I mean, Smile should be happy that, with their profile, they're getting absolutely neutral. When you have a complete neutral, the patient start compensating from the lens. This is internal aberration. This is pre-op, and you can see the lens was absolute, and then suddenly he starts compensating. And when you compensate from the lens, they start regressing and they have a lot of issues. So how are the aberration managed and how do you go for it? To understand this, we had to go to a little bit more deeper into optics. It's like this is the optics lab. Adaptive optics is like a phoropter. It's like how you have a phoropter, you can use the same phoropter. If patient sits here, uses his eye, and you can virtually change all his aberrations. You can put in coma. For example, I can sit on here and I can induce aberrations, something like a keratoconus eye, and I can see how I see if I had keratoconus with that aberration. Or you can remove everything, all the aberrations from my eye, and see how I would see. And I would probably add some more or delete. So basically, you're like how you use your -2, -3 phoropters, you actually play around with aberrations. And why it is important is aberrations are like commensals. You need them to have a healthy vision. Knocking them off is not going to get you anything. You have to keep them. So this is an experiment my colleague Dr. Pooja had done, where you are trying to use a lot of aberration, changing the aberrations, changing the coma to see which one will be the best one. And each one of us have our own set of aberrations which we want to keep. That means some of us may like coma, some of them might like vertical coma. Now the challenge here is no machine actually knows which one is your preferred and which one is not your preferred. So they just keep your profile aspheric, but they don't know, and nobody can tell you, because adaptive optics is not something which you can use in your day-to-day practice. So what is unique in Schwind, even though they don't talk to each other and they don't connect to each other, one of the things about Schwind is that there is something called as a manager. And when you click on it, you get this profile of all the aberrations. And that is called a minimize function, where it knocks off ones which are all in red. It keeps them, and ones which are in green, it just knocks them off. That means it doesn't correct them. It just keeps, so that basically you save tissue by doing this. And by it, sometimes it tells you that it can change your aberration. So what we try to do is, for a lot of our very aberrated eyes, when we treat keratoconus, we started using this profiling and check which aberration I should keep and which aberration I should knock off. Surprisingly, there are many keratoconus patients who would want to keep their spherical aberrations, and some even want to keep their coma. If I change the coma here, if I remove the coma here, his vision actually drops. And that is one of the reasons when you do a customized treatment and one of this process, when you knock off everything, that sometimes patients don't see well because you're knocked something probably which would get benefit from. My data is, it's a very laborious and long process to study them. But at this point of time, we are using, Schwind is one of those places where I can actually knock what I want. I can use, for example, I can keep this on. I can, in this, for example, I have knocked, all the greens are knocked ones, which is corrected. and all of them are the ones where I don't want to correct. So how do we know at this point of time? It's very difficult. Now I have to go back and use adaptive optics, which I think it will come to your practice. And finally, this is the outcome which we have. So finally, in the true era of customization, the few things which we need, which are controversial, are epithelial profile. Very little is spoken about it. We use epithelial profile to understand epithelial thinning or early changes, but I feel a good Contoura work should involve it. Role of lenticular aberration has been discussed. I think all aberrations are for epithelial aberrations is also very useful. The whole Zernike maps and the lenticular aberration, the whole interaction with them is probably very, very useful in the future thing. I wish you all be safe. We are all not in the same boat, but we are all in the same storm. And eventually, I think all of us will meet in some physical meeting or the other. I thank the speaker and Dr. Mark Lebanov for a beautiful lecture. Thank you.
Dr. Rohit, you are always inspirational, and that too repeatedly. You always bring something innovative to the table. Really impressed with the way things have gone. I have three things to do. Number one, there is an interesting question which Dr. Nitasha had raised regarding your talk when we were discussing over a phone. So can I ask Dr. Nita to ask that question directly to Dr. Rohit?
Dr. Rohit, that was very, very complete and covered up all the layers right from the epithelium to the lens. It was very interesting to hear your session on MS39 some time back. And I wanted to know whether you are able to use the data, like the way you showed that if we take away the epithelium, the power is different. Are you using that power when you do the Contoura calculations as yet? And do you have anything to show how it changes the Contoura calculations?
If your epithelium is very irregular, and if you have a very high cylinder which you don't match to your patient acceptance, then I would think of doing a wavefront optimized than do a topo guided treatment, because the machine assumes that the topo guided treatment is problem with the stroma, but your problem is not in the stroma, it's from the epithelium. So epithelial map is probably going to be a very useful tool in the future or even now when you're treating, especially when you're treating these patients who are very, very fussy about getting the right bang on thing. And if you go back and look at all your irregularities of your cylinders versus acceptance, then you go back and look at your epithelium, it will be regular. And one good thing about the MS39, it gives you a close to 9 millimeter or to 10 millimeter zone of epithelial maps, which is a larger zone compared to a smaller zone, what you see.
I have to agree with Dr. Shetty. The epithelium is very, very important, particularly if you're doing a topography guided PRK treatment. So one of the things that we're doing at FourSees is we're taking OCT epithelial thickness maps, pulling it into the software, using the geographic imaging software to analyze areas of thinning and thickening. And then we can calculate the refractive effect of what happens when you remove that, because it's much like removing stromal tissue that is elevated or depressed. So this is the next step. I think you're onto something. It's very important.
So this is exactly what we've been doing, Dr. Rohit, shifting those patients to WFO or treating them for a while and then getting them back in for surgery. What I wanted to know from you is, are you getting any quantitative data from the MS39 which you can use directly, or you still stick to the old way of doing WFO or treating the dryness and epithelium?
I have a different software, beta testing software, MS39. In that, there is one place where they click and say the whole image from the stroma can be transferred to Schwind. That means that there is they might be working now. I think the future generation of lasers will have to treat your stroma, not the epithelium. And there are machines now. I mean, if one machine has come, CSO has come, I'm sure that tomorrow Pentacam or somebody else may also come to this. About the quantification, what we are trying to do is with a colleague of mine, Dr. Gaurav and team, we are trying to build an AI model of because it's very impossible for a human mind to do a stats and figure it out. So we need an AI model which is going, now the work is going on, they were extracting the data. Maybe a month or 2 months later, I'll tell you how do you quantify if you don't have an MS39 with that data. So we have to find tools where we should be able to tell you without having a particular thing. So if you just have a pentacam, what irregularity actually means that this is because of epithelium. But that if we are building an AI model at this point of time, the work is going on, and only AI will tell you maybe in a course of time.
Rohit,
very good discussion. I would ask Dr. Ramurthy. We have two things here for the benefit of all the attendees. Can you sum up what is the take-home message, and can you sum up what are the challenges? Before that, if you want to ask any question, please go ahead.
I had a question before you go on with this, Dr. Ramurthy, sir. Rohit, you've used both platforms, the Schwind and the Alcon platforms, and both have excellent capabilities for topo-guided treatments. How do you see the difference between these two? Like Contoura, of course, is specific to the Alcon machine, but Schwind seems to have more flexibility when it comes to topo-guided treatments. How do you choose between the two, and what do you think is, how do they compare in their capabilities?
Yeah, very good question.
The Schwind, one of the things about Schwind is it's very, very, you can program it. It's not a locked software. If you are a little inquisitive, curiosity-driven person, you can play around with it and you can make your own sim. Contoura in that way is pretty locked. I mean, you can only do certain things with it. The second is the whole software in the Contoura one is quite organized. They tell you what it's happening, what points are there. Schwind, you don't have all this data at all, and it doesn't take the cylinders from. It only goes by the acceptance of the patient. You don't get the cylinders from this. So there are advantages and disadvantages for both. But I would feel that one thing about Schwind is that they also have something called as the total wavefront guided treatment, where if you feel that if you have a very high level of patient has a very high anterior and posterior corneal cylinders, you can actually do a wavefront guided, and it actually saves a lot of tissue. So I would say that at this point of time, Contoura has more organized their software. Schwind is very organized, but it gives you a lot of options for you to change. And changing is not something everybody wants to do because nobody has time to sit and do all that. But if you want to do it, you can do it. But
so customization is,
yeah. But I feel that for keratoconus work, I completely shifted to myself to Schwind because I can really modify a lot. And if you do your topo-guided treatment on your TCAT, you virtually have no idea what is treating and what is not. For example, if you are treating a central cone, you would want to treat a spherical aberration. If you're doing a decentered one, you don't want to treat a spherical aberration. So you can actually off it, on it, and you can play around with it. So it's giving phenomenal results.
Thanks, Rohit. And in fact, before I ask Ramurthy sir to sum up, here we have a panelist, Dr. Arulmoy Varman. I don't know if he's still, if he's online and listening to us, because Vavikar, we wanted to ask, like non-Alcon and non-Schwind platforms, if he could chip in with how he customizes on his platform. He's using a totally different platform as well. And do you have something similar to our what we do on the Alcon platforms as far as Contoura goes?
I'll chip in here that what I noticed is that the iDesign of Vuzix has been doing a topo integrated model of treatment for several years. There's nothing new about it. It has a topography capability on the abrometer. The abrometer throws in the dots, and what they call as a full gradient method, they looked at the topography, and also that was included even 5 or 8 years ago. But at that time, the whole emphasis what I see on the Vuzix is to negate the cosine effect by applying the proper corneal curvature. So the cosine effect is not just negated by a mathematical algorithm, it is personalized. But in the older, the one version, the Vuzix iDesign 1 version, it was taking an average. While what I have for the last couple of years, the iDesign 2 actually looks at multiple factors, multiple points in the cornea, does a more robust topographical evaluation, and the treatment is completely topography guided. In a word, they call it as topography integrated and wavefront guided. It also separates out the total aberrations from the corneal aberrations, but does not give you too much freedom of you deciding what you treat and what you don't. As Rohit was saying, yes, the Contoura gives you a certain amount of freedom, while Swin gives you a lot more. I guess the Vuzix doesn't give you too much of a freedom, but it does look at the corneal topographic evaluation and does give exceedingly good results. This is something that's been there for a long time. I've been talking to them about giving us a lot more freedom where you can choose to leave something back or treat something, and also completely dissociate the refractive treatment from the topographic treatment, which would be the final gold standard to go and make a irregular cornea regular, not treating the refractive outcome at all. And that will probably help us in a lot of situations where you have a very irregular cornea, like post PK or a post or a treated keratoconus. So we like to have a platform that would let you completely turn off the refractive status of the whole eye and treat only the corneal aberrations or the corneal irregularities, and also let you choose what you want to treat, what you don't want to. I guess we are very, very close to getting to a platform like that.
Thanks, Dr. Armoy, for those nice things and inputs. And I think, now all regards around Dr. Ramamurthy, before we have the master of, he has an amazing talk coming up, Dr. Sanjay Chaudhary. So before, we'll sum up this part of the symposium, and then a very interesting topic coming up after that.
I think it's been a very interesting evening, and we have been we are spoiled for choice now. Ray tracing should have been the final talk, I think, but it was a wonderful talk that was given by Arthur right in the beginning. And to me, that seems to hold a lot of promise for the future, because it takes into consideration almost all the refractive surfaces that we come across. And it seems to be a very objective measurement of what we are going to treat. And of course, then there was a significant discussion about the Contoura and its limitations. Obviously, it is a way forward, but then Wavefront Optimized is already such a good platform, and trying to improve upon the results further is obviously a challenge. And then there is a certain section of eyes where it seems to perform well. Of course, Mark rounded it off with his excellent discussion on FourSees that again takes into consideration so many other aspects. And I believe having so many different platforms available to us to pick and choose as to what we can offer is a great place to be in. And Rohit, as usual, with his take on the epithelium and an overview of all that is involved in refractive surgery, sort of rounded off everything. One thing I'm always concerned about is the final thing that matters to all of us is, the satisfaction levels that we're able to give to our patients. And I look back upon my refractive career with a plano scan, which started almost 22 years back. My patients were quite happy then. And today also, finally, the happiness quotient, whether it has significantly risen, I'm not so sure. I'm absolutely convinced that, compared to using a microkeratome, a femtosecond or a smile is the right platform as far as creating a flap or a cap is concerned. But when it comes to choosing between these different platforms, whether everything differentiates into an incremental improvement as far as the patient experience and patient outcome is concerned, that's a question that remains in my mind. And finally, as an introduction to Sanjay's talk that needs to follow, I think the first slide that Rohit used of Mona Lisa, all of us must have been to the Louvre Museum. I often wondered, it's nice, it's great, but there's so many wonderful other paintings that are there in the museum. Why is it that it's world famous? I think it's the marketing, the hype that has been created about it. So whatever be the platform that you use, whatever be the technology that you use, I think you need to sell it well, because you can't differentiate the science from the commercial aspects of ophthalmology. I think it's a nice way to round it off with Sanjay's talk about marketing, whatever platform we are using. Over to you, Sanjay.
Absolutely, absolutely. So I have the privilege of introducing Dr. Sanjay Chaudhary, a dear friend. He revolutionized Contoura treatments in India by bringing it to the forefront. And many of us were doing Contoura when suddenly one day patients came in asking that, do you have Contoura? And we were not actively like kind of marketing it. And then suddenly we started thinking, oh, where did this demand come from? Suddenly everybody seems to ask that, I want to do Contoura, and they find you and say, okay, Contoura Vision. And I said, oh, we've been doing it, but we never thought of marketing it like this. So he's the master of bringing it to the forefront. And yes, today's talk is very relevant because we've seen in the last few months how our businesses have been hit so bad, especially refractive surgery. And these are difficult times for refractive surgeons. So, or maybe good times, as in Hong Kong, they said they actually started doing more than 100% of their previous volumes because young people are still happy to come. So your inputs, sorry.
That was 1 month back, wasn't
I know.
in Hong Kong.
maybe no longer true. But I think right time for Dr. Sanjay Chaudhary to come guide us about his take on how he went through his last few years of bringing Contoura to the top of the Indian refractive surgery market, and how he's coping with the current situation as well. Dr. Sanjay, chairman of the I7 group of eye hospitals, doing tremendous work in Delhi with many branches, and it's a privilege to have you on board with us.
Thank you, Gaurav. Thank you so much, Dr. Gaurav, Dr. Vavikar, Dr. Ramamurthy, and all the esteemed panelists here. So we are sitting in difficult times. Contoura all over is eating into a share of patients which are coming into the center. We are all tight on budgets. We are waiting when this thing is going to go away and we'll get our revenues back, because things to sustain is very expensive, equipments, salaries, everything. So some people even are wondering, should we do marketing at all? And if marketing, where should we put in our money? So I collected some thoughts around all this and made this presentation. What is this? Okay. So how is COVID impacting eye surgery today in India? Talking to a lot of people, we feel that cataract surgery is about 20 to 30% of the normal for this time of the year. Refractive surgery, surprisingly, is doing much better, 50 to 60% of the normal. And ICL, I talked to the STAR people, they said it is about 10 to 20% of what it should have been at this time. And surprisingly, ICL is not doing too well in the north, but it is faring much better in the south of the country. Why? I really don't know. So, wondering why cataract is down? The answers are obvious. People are afraid of visiting a hospital because they perceive that even COVID people might be visiting those hospitals. And surgery is not an emergency, it can wait. Just an anecdotal example here. I had a small problem and wanted to visit my physician. I called him up. I said, Chauhan, I'd like to see you. He said, come over to the clinic. I said, yeah, not the clinic. Can I come down to your house? He says, come on, yeah, if doctors are going to say like that, what about the rest of the public? But still, if you're so fussy, I'll come down to your car and have a look at you. So this is a reflex of every person in society that they want to avoid public areas, especially the hospitals. So a little dejected projection for ophthalmologists. You can consider this year is gone. If you can sustain through this year, great. So the inference, why invest in cataract marketing now? Since refractive is doing well, and we know why refractive is doing well, it's the young people who want refractive. Young people are less afraid of COVID. and they want to utilize this free time. So they say, okay, why not get my refractive done and get my glasses off at this time? Let me make use of whatever is happening around me. So if you do want to do some kind of a market, it is worthwhile considering the refractive market. And if you are again into market, you have to focus on that element which is afraid. I'm afraid of coming to a medical establishment. So marketing principles have always been the same. Print is more or less obsolete. It is all about digital marketing. And even in digital marketing, there's so many things which are coming up one after another. You really have to keep pace with all these things coming up. So you can now almost say, even though digital marketing is new, I can say that there is a conventional digital marketing and there's a newer digital marketing. Conventional is all that we have heard, and probably a lot of people have gone on to the conventional marketing, which is, can you hear me? Hello?
Yeah, we can hear you, Dr. Sanjay. Please go ahead.
Okay. So you have the regular ones, the Google AdWords, YouTube videos, YouTube channels, Google reviews, Google ratings. I think by now, almost all ophthalmologists know about these modalities, and quite a few are already practicing these modalities. But then there are some new ones which are coming up these days. I'll just show you a couple of them.
Hello, everyone. Welcome to YouTube live session part 2. In the first live session, we could not cover all the questions. So on popular demand, on all of your requests, we are doing a second session of this YouTube live. Hopefully, we'll be able to cover all your questions, but 2.75 in both eyes what to do. विकास जी बहुत सारे आपके पास ऑप्शंस हैं, लेकिन इस टाइप का नंबर यूजुअली हम लेजर सर्जरी से करेक्ट कर सकते हैं. लेजर सर्जरी में भी बहुत सारे ऑप्शंस होते हैं. ब्लेड.
See, so this is one of the ways you do live sessions with a target audience, answer their questions, keep them engaged. They should know about your presence, so that if they plan to come now or they plan to come later, at least they are engaged with you. So you don't lose out on your person when he finally decides that yes, I will.
So यार अभी मैं आ गया हूँ I7 चौधरी हॉस्पिटल में.
Now this is another very useful tool. The influencers. Why is it useful? Is because there are these YouTube influencers who have huge following. They could have lakhs of followers. They could have millions of followers. And there are normal looking guys. You just won't believe that this guy could have so many lakhs of followers. He turned up at my clinic and he said, I'm a YouTube influencer and I need to get my Contoura done. So I got interested. We did do his Contoura, and then this is what
लाजपत के अंदर है, क्योंकि मैंने जहाँ तक भी ऑनलाइन वगैरह पढ़ा और भी मेरी फैमिली लोगों ने रिकमेंड करा, तो मैं यहाँ पे आ गया हूँ. अंदर चलते हैं, बात करते हैं कि क्या क्या प्रोसीजर है इस चीज का. तो आओ यार. आपने जैसे कि देखा कि ये पूरी मेरी सर्जरी थी और अब मैं बिल्कुल ठीक हूँ. आप देख रहे हो मैंने चश्मा नहीं पहन रखा और मेरे को बिल्कुल सब चीजें क्लियर दिख रही है. अगर आपको वीडियो अच्छी लगी हो तो यार वीडियो को लाइक जरूर करना. भाई देखो, मैंने बहुत हिम्मत दिखाई थी कि वीडियो भी शूट हो रही है और मैं उस टाइम पे ऑपरेशन करा रहा था. तो अगर आपको वीडियो अच्छी लगी हो तो यार वीडियो को लाइक जरूर करना, अच्छे कमेंट करना, वीडियो को शेयर जरूर करना और चैनल को मेरे सब्सक्राइब जरूर कर लेना. और जिनको आपको लगता है कि जो मेरी तरह जो ये इस सर्जरी से डरते थे, उन लोगों को वीडियो जरूर भेजना कि भाई इतना डिफिकल्ट नहीं है, इतनी कोई ऐसी दिक्कत नहीं है. तो ऐसे उन लोगों को भी पता चल जाएगा. बाकी नेक्स्ट व्लॉग में मिलते हैं. बाय.
This guy had a fan following of 50 lakh youngsters, and when he put it out there, you can well expect the kind of a response that it generated.
Hi, I'm Dr. Aditi.
I'm Dr. Rahil.
And here's another one. Here's what is called YouTube autocomplete. You'll notice that Sanjay Chaudhary is no more a marketing man. It's his son Rahil Chaudhary who is the marketing genius. He comes up with newer and newer things, and he just keeps telling me, now this is what we are doing, and now this is what we are doing, and this is what we are doing. Here's a very interesting one. When you feed something into the Google in a search, when you say Lasik or something, then it comes up with various suggestions. Lasik in this, Lasik in that, Lasik complications, Lasik when it should not be done, what are this? So there are all those questions. That means somebody somewhere has typed those search words, and Google is using those search words. So that means these are questions which need to be answered. So this is what Dr. Rahil Chaudhary is
Today we'll be speaking about Google autocomplete.
So Google autocomplete basically means the most asked questions on Google.
And today we'll be discussing Lasik.
So Lasik is basically a technology to remove your glasses. So let's start?
Yes.
Okay. So first question, can Lasik be detected?
Yes, it can on our machines, but not on torchlight.
Yeah, so basically routine examinations, Lasik cannot be detected if somebody is checking you on a torchlight. But if a doctor is checking you on a slit lamp, or if he's doing a topography test, then of course Lasik can be detected.
Right.
Can Lasik be done twice?
Yes, it can be.
So that's a very interesting question to say. And then we look at the next option. The patient is afraid of coming to the center. So you need to tell him, well, please don't be afraid when you come to our center, because we are taking all the precautions to do our level best that you do not have a problem, or you do not have a possibility of getting contacted with corona. So you need to show that to him before he visits your center. So here is a way to show to him online. So when you make these videos, and there are the whole lot of youngsters who are assessing you when you see these videos, when they see these videos. So you definitely need some professional help to make videos. It really matters how you present yourself to your audience. There are, of course, so many new marketing ways coming out that probably you would need a session of 2 hours if I was to take you through all that. But these were just a few salient points you could think of using in your routine marketing practices. Thank you so much.
Thanks, Dr. Sanjay, for those amazing insights. I think everybody was sitting spellbound by what you were trying to tell us. These are all innovative new ways of seeing a totally different aspect of refractive surgery, which is equally important as what we discussed in the sessions before. So COVID times, I think what you touched were very, very important points, making people feel that they are safe. And of course, the youngsters who are willing to come, and then convincing them that they're getting the best treatment. And all the social media and YouTube influencers and stuff, all this is fantastic. So did you see a change, like when lockdown happened? Did you temporarily withdraw all your advertising and stuff, thinking that probably, for a month or two, and then when you restarted, did you restart in a different way from what you were doing before? because you were onto social media marketing and online marketing even before. And this is probably something where, do you think that it's still wise to invest into marketing at this time?
Yeah, in fact, the moment the lockdown happened, everybody was panicking that how will we get our funds? Let's conserve on the funds, stop everything. Even some people were retrenching, some people were reducing the salary of staff because everybody was asking everybody questions. How are you going to manage? And the bigger the institution, more the drain.
Absolutely.
Because there's so many employees working, what do you do with them? So, but then a month and a half through this, we got thinking and we talked to people about statistics. How is Cataract doing? How is Lasik doing? And we got the answer. Now we have a huge panel here. So does these percentages fit that Cataract is about 20 to 30% all over? Does it fit that Refractive is about 50 to 60% all over?
Let's take a poll. Let's take Bombay, Dr. Vavikar and Dr. Nitin and Dr. Neeta.
In Bombay, it is very bad. It is less than 25%. Whatever. Even refraction is 23%.
OPDs. I think Coimbatore saw better situations. I mean, Coimbatore was less hit. And Dr. Ramamurthy, how was your experience at your 7-8 centers?
No, actually, June was quite good in the sense that we almost had 75-80% all across our centers, except maybe in Cochin. Even Bangalore did reasonably well. But after June 20th, 25th, thanks to patients being exported from Delhi, Bombay, and Chennai, we are also catching up, finally, and now volumes are down. And definitely, it's about 25-30%. And surprisingly, in contrast to what Sanjay was saying, we find that our cataract patients are reasonably all right, still about 35-40%, and refractive surgery patients are a little less. Especially in Bangalore, I find that many of them are on the bench. They are not sure about their salaries, whether they can meet their financial commitments. So they don't want to really spend on a elective surgery like this. So I think different areas, different experiences, but we are definitely going to
Delhi. Yeah, in Delhi, I believe I talked to a lot of people. Refractive, for whatever numbers they were doing, it was coming out fairly well. Cataract, of course, everybody is at 20% level. ICL people I talked to the start, how is it faring? Not probably ICLs are coming not only from the city itself, but a lot from the states, which are feeding the major city. Sorry?
Talk to IOCare also, I said.
Yeah, I should have done that too. We wonder how's the experience with the IOCare thing. I mean, anybody talked to them and said how their lens is moving?
No, I think the phakic IOL market sort of mimics laser vision correction, and both of them go hand in hand.
But at Sanjay's place, it's probably not going the same way. But Rohit, I'd be really interested. Bangalore saw a lull. I mean, we didn't have too many COVID cases in the first 2-3 months, and then it was like doing really well. And then suddenly last month, we've seen a spurt. How has the experience been in Bangalore?
See, in May, we were close to 50%, 50 to 60%. June, I think we were close to 90% of normal in all fronts. Unfortunately, July, there was a spurt. So we are like around 40 to 50%.
So is there a difference between refractive and cataract?
It was the same. We were surprised that in the month of May, it was like 65%. Maybe there were all spillovers from April patients. So we can't be sure. But June was good. But I mean, surprisingly good that it was close to 90-95% what we would do in a normal month. So May we were really, I thought it was just the spillovers. In fact, I agree with Ramurthy sir, if the things were moving that way, I think we were, but now again, we gone to around 50-60%. But I would agree with Dr. Sanjay sir that the younger people are the ones who are coming for the surgery, because it's been drilled very clearly that your refractive practice will pick up faster than a cataract practice, because people think that the elderly after 50s, 60s are the ones who should be sitting at home. So this, I think, was brought out very beautifully in one of the meeting by Don Chang and in one of this webinars. He said that refractive practice in Hong Kong has been 100%.
Or even more.
Even more. He says he's doing much better than what he did before because all the people are coming out for refractive surgery. So cataract, I think, would take a longer time, and of course, all the other specialties have been completely hit.
But for those of us who are doing, between SMILE and LASIK and femto LASIK and PRK, like Dr. Ramamurthy, Rohit, do you see a preference for one procedure over the other has changed because of this, or do you notice that people still tend to go for the top procedures, or they're opting for the lower procedures? And that question is for all of you. Do you notice any difference in preferences?
In my view, refractive is refractive. So people can still afford because they still have the money. They're just trying to save on their money, but they're not trying to save on the quality. So a refractive patient who is a premium patient is still a premium patient.
What explains the ICL drop then? I mean, if this was not, do you think that's because they think it's more invasive that the ICL volumes dropped for you drastically?
The lenses are not being shipped. I mean, we have something like 10, 11 lenses ordered, and there's a huge crunch in the courier. I think it's more related to the lenses not being shipped properly, and some of the lenses which are supposed to come from outside, like Zurich, are not coming. So I think it's patients are there. It's only that this just got stuck. But like from Chennai, the courier service was not working the whole of last 3 weeks. It was not working, and suddenly they sent it to some courier, and we had to go pick it up. There's a lot of hassle.
Yeah.
I think there are two observations. I mean, one is that a patient who walks into the clinic is confident of getting a procedure also done. Those who are scared, like, Sanjay mentioned about his reluctance to go visit a doctor, they don't just come to the hospital. So our OPD numbers have really dropped. But those who venture out and come and meet us, if they need a procedure, they are willing to go ahead and get it done. If you give them the right kind of inputs and encourage them to get it done. But Rohit, I mean, just for some clarification, that study that you have done with the Indian Institute of Science, I think it's being quoted differently in different media.
I know. I pointed that out. The Hindi newspaper said a totally different version from the English one, and that was so funny. Yeah.
Some clarification, so that the lay public are not confused. I mean, it should not be that.
The challenge with newspaper, I've realized, is they don't want to write anything which is positive. They don't want to write that it is positive. So whatever it is, we have come into a stage of having negative journalism. So there is nothing called positive. And I asked one of the journalist friend, they said nobody wants to read a positive thing. They don't want to see a doctor dancing and keeping the COVID patients happy. They want to see some doctor not seeing a COVID patients.
I know.
That sells more than that. And in fact, we have this whole report was given by Indian Institute of Science. They didn't even, because Indian Institute of Science, when they send a press report, 100 press people pick it up because it's a scientific body.
And they interpret it differently. Each one of them interprets it differently.
But sir, I went through the original press report given by IIRSI. It was very clearly stated how it is beneficial, and they have omitted 3 paragraphs. And then I asked the IIRSI to take a clarification. Then they said that this is can't, and inside information is that they don't want anything to be positive. In fact, if you want to be on a press today, you just have to come out with something which is completely negative. That COVID can spread from conjunctivitis, if you say, you will have a much better thing. So it happened in Bangalore also. Minto Hospital did a very nice study. From say 140 patients admitted in COVID in the COVID ward ICU, they took the swab, and they did only one patient had from the tears positive. And for 3 days, the newspaper and TV channel carried report in Bangalore. You can ask your colleagues in Bangalore.
We saw it in Coimbatore also.
Whole week, the OPD dropped to 80%. And only one patient out of 165 people, they did not write that 165 people had negative tears. It cannot spread, and they just picked up one. So you have no control. Once it goes to that domain today, you have no control on anything. In fact, the Times of India had a different report. The Hindu had a different way. In fact, and Hindus was little better.
The Hindi newspaper carried the best report of all. It circulated all over North India,
Yeah.
It kind of put across that eye surgery is safe in COVID times. And that was again reference from the IIS and Narayan Nethralaya report. So I think they were being more responsible than, some of the English newspapers. That's so funny. But I think you're so right. The media has its own way of, they've gone totally, they only use this as a marketing tool for their TPR or whatever they call it. But I think we've had a great session, and thank you so much for all of you chipping in with such amazing inputs. And I think each part of the symposium was great. Dr. Vavikar was able to bring out the best from all our international speakers, our other speakers, and thank you to all our topmost faculty for joining us today. Each one of you, Dr. Neeta, Dr. Arul, Dr. Rohit, Dr. Ramamurthy sir, Dr. Sanjay. I think we missed Dr. Dhami and Dr. Maipal. Dr. Dhami was there for a while, but I saw him leave at some point. Dr. Nitin and Nikhil, of course. Thank you, each one of us, and those of us speakers who already left for the day. It was a great session, and we look forward to more such interesting sessions. And I would like to thank our IIRSI office bearers who were responsible for allowing this session to materialize. Dr. Amar Agarwal, Dr. Maipal Sachdev, Dr. Dhami, and our whole team. And all our viewers who have stuck with us right till the end, and of course NTOT, who were always available to make all the necessary changes, modifications, and helping us reach out to all the viewers on all the social media channels. So thank you so much for joining us today. Dr. Vavikar, you have the final word here.
You already echoed all my points, but thank you everybody. All the lecturers were really good. There were a lot of take-home messages and some original stuff from Narayan Nethralaya. And Dr. Ramamurthy's lecture also very eye-opener, very lucid language. Both the international speakers were really good. Dr. Arul Mozi chipped in very well. He had a very small time to answer, but he was absolutely to the point. So I'm really thanking everybody for giving us this opportunity of getting the best out of the topic. And of course, thank you to NTOT. They are always been very supportive, and this is one of their things. What I hear is that the live people like attendees, we have crossed 5,500. So that's quite a number, right? For such a niche topic. So congratulations, everybody has contributed. Thank you very much.
Congrats.
Thank you.
Thanks.
Thank you, Gaurav.
Nice to be with you guys. Wonderful.
Thanks.
Yeah.
So
thank you.
till we meet again.
Bye-bye.
Bye-bye.